Good morning, everyone. My name is Jalesh Panikar, and welcome to the next in our webinar series from the Neurology Academy. It's got a rather catchy title, When Brain Meets Bladder, and it's about the neurogenic urinary tract dysfunction explained and managed. And to explain and manage this, we have a star panel this afternoon. But essentially, this webinar is about the lower urinary tract symptoms that occur following neurological disease. Many of you in this webinar will be aware about the impact this has on quality of life and independence and rehabilitation outcomes. And through the course of the next hour or hour and 15 minutes, we hope to take you through the assessments of individuals with neurological conditions who report urinary symptoms, and in terms of practical management strategies. Also delve into sort of the interplay between neurological disability and urological dysfunction. And so we hope that at the end of this webinar that you would have a sound understanding of the neurophysiology of bladder control, the presentations and management of neurogenic urinary tract dysfunction, and the impact on quality of life, polypharmacy, rehabilitation outcomes, and explore practical management strategies, both from a neurological and urological perspective. And it's with great pleasure that I introduce to you the faculty of this webinar. So myself, I'm its chair, and I'm actually a neurologist with interest in neurogenic bladder bowel sexual dysfunction based at University College London. We have Ms. Sheila Reid, who's a consultant urologist at the Sheffield Teaching Hospitals, Professor Shiva Nair, who's a neurologist at Sheffield, and Mr. Liam Rice, who is an MS specialist nurse in Sheffield. For the next hour, we'll be taking you through a series of presentations. So without further ado, it is my pleasure to introduce Ms. Sheila Reid, who is, I would say, probably a doyen in the field of neurourology in the UK, if not abroad, a urologist based in Sheffield who will start the webinar. Sheila, over to you.
Just a little bit about me to start with. As Jalesh says, I'm a consultant urologist. I have specialised in neurourology for nearly 20 years. I'm attached to the spinal unit in Sheffield. And during that time, I set up and ran an MS urology service in Sheffield with Liam Rice, who's our next speaker. So a lot of the pathways we developed together, and they're very relevant, I think, not just for MS, but for lots of urological conditions. I actually took semi-retirement about 18 months ago, and during that time I have done quite a lot of work for the Spinal Injuries Association, the Shine Hydrocephalus and Spina Association, and the MS Society. So Jalesh has already gone through the objectives, and my main part of this seminar is to try and help you understand the neurophysiology of bladder control and presentations and management, and really what you should be doing as a non-neurologist to manage and who you should be passing on for expert care. And to understand neurophysiology, the first thing you need to understand is the anatomy of the spinal cord. Nothing very much about it, but just the fact that bladder, bowel, and sexual function are innervated from the sacral segment of the spinal cord, that is S2, 3, and 4. But that part of the spinal cord actually sits a lot higher up anatomically than you think it is, because the spinal cord ends at the upper border of the L1 vertebra. And below this, you have the cauda equina. So particularly in spinally injured patients, when you talk about levels of injury, it's important that you understand, is it the bony level of injury or is it the neurological level of injury? And neuropathophysiology, this diagram looks very complicated, but actually there's only a few things you really need to know about it. The first thing is the innervation of the bladder. So the S3 sacral segment innervates the bladder, and it innervates the bladder from the sacral micturition center, causing bladder contraction through the parasympathetic nerves. And there's a reflex that is completely a spinal reflex. So when your bladder fills, it triggers goes through the sacral micturition center to trigger bladder contraction using the parasympathetics. The second reflex is what we call the guarding reflex. And the guarding reflex goes through Onuf's nucleus, but it's also through the third sacral segment. Onuf's nucleus is an anterior horn cell, so it's like all the other anterior horn cells down the spinal cord, and it innervates the rhabdosphincter using somatic nerves. The rhabdosphincter is the main portion of the urethral sphincter, and it is the bit that really keeps you dry. And this reflex is called the guarding reflex. So when urine comes into the proximal urethra, it triggers contraction of the rhabdosphincter. All of this is controlled through the pontine micturition center, so that when your bladder fills, it is not contracting, and when it empties, the sphincter is relaxing. The cortex does very little actually, and I'm going to give you some more examples of this. It just gives you sensation and voluntary initiation. So these slides, I think, show very clearly how this works. So as your bladder starts to fill, you'll see the yellow contrast filling down below. It starts to send signals up to your brain. In that state, the bladder contraction sacral micturition center is being suppressed, and Onuf's nucleus, that's a sphincter, is being augmented. And as your bladder continues to fill, complicated things happen up in the brain to eventually tell your brain, how full is my bladder? I actually need to go for a wee now. Is this the right time and place? Just bear in mind that the storage part is 99.8% of the time. So this is the time that you want the bladder to have a low pressure. I'm going to be talking a lot about bladder safety. When you are ready to void, and by that I mean you are on the toilet, got your trousers down, whatever you need to do, then the brain tells the pons that you can allow this person to wee. But it is the pons, the pontine micturition center, that allows that to happen. So it switches the two reflexes. It augments bladder contraction and it suppresses the Onuf's nucleus. So you contract your bladder and you relax your sphincter. So I'm going to introduce you to these guidelines. These are what we call NICE guidelines from the National Institute of Clinical Excellence in the UK. And I appreciate there are people on this call who are not in the UK. I still think you should read these guidelines because I think they're really good and they're really simple. And I've got a link to it a little bit later on in the talk. Although they were published in 2012, they have been updated in 2023. And they divide neurological conditions into three. That is brain conditions. That is any condition above the pons. And if you think about what I've said, any of those conditions, although they may affect your continence and affect your sort of social ability to void, they're not going to affect bladder coordination. Secondly, we've got suprasacral cord conditions, and suprasacral cord conditions mean above the spinal sacral cord, not above the bony sacrum, and that's really important. And the point about classifying it in that way is because that part of the sacral cord is still functioning, and it's functioning fine. There's nothing wrong with that. What is happening, particularly if you've got a completely suprasacral injury, is that it's not connected to the brain any longer. And if it's not connected to the brain anymore, that means that as your bladder contracts, it will actually stimulate the guarding reflex at the same time. So you get detrusor sphincter dyssynergia. The bladder is contracting and the sphincter is contracting at the same time, and that causes high pressures. And the third classification are sacral spinal cord problems, and that is when that S3 segment is not working. So that may be trauma, it may be ischemia, it may be inflammatory. This also applies to peripheral nerve conditions. So basically, there is no innervation able to go to the bladder or to the sphincter. What I didn't mention in my previous slide was about the sympathetic input. And what the sympathetic input does is that it allows your bladder to relax as it fills. So it gives you normal compliance. And we sometimes find in those sacral spinal cord conditions that that sympathetic innervation is lost. So that can be a problem with bladder safety as well. It also gives you a table which gives you some good examples of the different neurological conditions in the different categories. There are excellent EAU guidelines on neurourology. And a third guideline, which came out last year, is the Neurogenic recommendations published in the European Journal of Neurology in February of last year. This is an excellent document, but it was written for neurologists, so not for urologists, but it gives some really helpful recommendations. So when you're managing these bladders, you need to think, what are the goals? And the primary goal is to protect the kidneys. I'll explain that in my next slide. Reduce complications, so there are obvious things like skin and pressure sore problems, but also in spinal cord injury patients, autonomic dysreflexia. And managing continence is only your third goal, so of course it's important, but the other things can often be more important. So I need to talk about what's a safe and unsafe bladder. So an unsafe bladder is one that puts the kidney at risk, and it puts the kidney at risk because of prolonged high pressure in the bladder. So it acts like a functional obstruction. If the pressure in the kidney is lower than the pressure in the bladder, it just can't drain. And that's really dangerous if that's prolonged, because the kidneys develop hydronephrosis, and ultimately patients will go into renal failure. And that occurs for two reasons: detrusor sphincter dysynergia or poor compliance. And the patients at risk are those with spinal cord injuries, spina bifida patients, and those with anorectal abnormalities. Obviously, this isn't a black and white list, but that's what it is. And men are at higher risk than women because men simply have better continence than women. This is the barcode that will bring you to the NICE recommendations. And I would just bring your attention to the second point on the right-hand side, that it does recommend lifelong ultrasound surveillance for people who are judged to be at high risk, with that occurring at least every 2 years. The European guidelines give the same recommendation. And just as you can see in the top box, worth pointing out that just be careful when you're doing blood test renal functions. Serum creatinine and EGFR may not be accurate for monitoring renal function in patients with neurogenic lower urinary tract dysfunction. So when do you need to investigate and refer to urology? This is when I think you need to investigate and refer. If you've got a patient with a high-risk bladder, they should be under specialist care, or at least have had a specialist assessment with a proper management protocol. Hematuria, anybody who wheezes blood needs an assessment. The microscopic hematuria is a little bit more contentious, but honestly, with the frank hematuria, particularly in the neurological patients, get them looked at. Recurrent urinary tract infection. If you're struggling with their continence, so Liam is going to talk to you about some pathways, and if that's not working for you, send a referral. Be wary of men with potential bladder outflow obstruction. They may need prostate assessments. This is a new addition to my slide here. It's don't forget ketamine. I don't know if people outside the UK are experiencing this, but in the UK, we're having a really big problem with ketamine abuse among our younger people at the moment. It's a drug of abuse. It's extremely cheap. And unfortunately, we're seeing an awful lot of young people around the country taking this. It gives the most horrible bladder symptoms. So if you've got somebody with new symptoms, just be aware that that may be something that's going on. We do have the facility in most of the UK hospitals to do a simple urine screening test for ketamine. And one of my favorite phrases is lack of clue. I think that is really relevant for a lot of these neurogenic patients. Sometimes they can be really difficult to manage. And just to show that it's not just my opinion, these are the Neurogenic red flags, and what they suggest needs specialist sharing of care. And one thing that I hadn't put in mind were catheter complications. So if you're getting patients with blockages, leakage, they may need specialist input. So just talking about imaging, the most common imaging we use is an ultrasound. And when we talk about ultrasounds, we talk about renal and we talk about post-void scans. Liam's going to talk more about post-void, so I'm going to stick with renal ultrasounds. And you need to do these for surveillance in the high-risk patients. I've said here urological problems needing neurological input. As a urologist, if somebody gets referred to me with a neurological problem, issue with a urological problem, I always do a baseline ultrasound because they've got a new urological problem. Recurrent UTIs need ultrasounds, or just they're not right. Ultrasound is a really helpful and non-invasive test. It gives quite a lot of information, but it does have limitations. It's not great at looking at hollow organs, so it's not great on the bladder, which is why we often do cystoscopies, and it may not show you a good representation of stones. So hematuria in the UK, if somebody's got hematuria, we have specialised what we call 2-week wake pathways for cancers. And that may not be applicable in other places, but just be aware hematuria needs investigation, and these patients may need a triple phase CT. Non-contrast CT is a really good examination for stones. It has relatively low exposure to radiation compared to a lot of other CTs, and it gives you really good information if there is stones, what size they are, where they are, and if they're causing any problems with obstruction. Whereas your ultrasound scan, it may show you your stones, but it's often a little bit inaccurate for size, and it does miss some of them. It will tell you whether or not the kidneys are obstructed. So cystoscopy, I'm sure everybody on this call knows that cystoscopy is a telescope examination of the bladder. We tend to do it in this patient group because we suspect bladder stones. We do need to be wary of cancer in this group of patients. Intravesical things that shouldn't be there. Unfortunately, these often tend to be iatrogenic. We get patients who have problems because they've had previous surgery, and I'm thinking in the ladies of the mesh, sometimes you get mesh erosions. If they've had previous surgery, they could be stitches, something like that. And then I put it quite simply as doing stuff. You can do a lot with the cystoscope, not just look. And the biggest thing, obviously, is Botox. When do you do it? You do it for hematuria, for recurrent urinary tract infections, if you've got a new urological symptom, but also if you've got a new neurological symptom. And Steve is going to talk about that. And just to point out that we have flexible and rigid cystoscopes. A flexible scope can be done in outpatients. We now have disposable scopes, which I always think is a pity, but we do, and we do use them. And even patients with completely normal sensation can tolerate this as an outpatient procedure. It is somewhat limited in the invasive procedures that you can do through it, which is why we also have rigid cystoscopes. We tend to use those in the operating theatre. So onto urodynamics. Urodynamics evaluates how well bladders and urethras store and release urine. And I think sometimes it can get a bit confusing because we talk about non-invasive and invasive urodynamics. So non-invasive urodynamics are when we don't use catheters, and they include bladder diaries, urofluorometry, post-void residuals. But I'm going to tell you about invasive urodynamics, and we do use catheters for invasive urodynamics, and they are a really important part of assessment for patients who are being assessed with neurological conditions. We tend to use video urodynamics, which means that the fluid that we use is X-ray contrast. We put a small catheter into the bladder, a small catheter into the back passage. Both those catheters are attached to pressure transducers, and we fill the bladder. Because we're using X-ray, we can tell not just pressure changes, but we can actually look and see what does it look like. Is there any reflux? Have we got dilated ureters? What's the bladder neck like? Is there bladder neck descent? And it gives us a lot of information. So who should have urodynamics? Back to our NICE guidelines. Urodynamics should be offered to those at high risk, and we've already talked about that. They should also be offered to those where you really can't figure out what's going on, or if you're going to do an operation. The European guidelines also give recommendations, and the Neurogenic guidelines also give recommendations. I thought it would be easiest just to put up what we say about multiple sclerosis, because multiple sclerosis is probably the commonest urological condition that we see, particularly for the non-specialists in the general hospitals. And most patients with multiple sclerosis do not need routine video urodynamics because they do not fall into that high risk category. However, they do need urodynamics if you're worried about their upper tract. So there are some patients with multiple sclerosis who do have problems. So particularly if you're seeing hydronephrosis on their ultrasounds, if they're not responding to management and you want to know where to go with this, so you've gone through your pathways, if you're going to operate on them, and as always with this clue, if you have a complete lack of clue, urodynamics is really great for really figuring out what's going on. I've only got one slide on this, but I thought it was important to include it because autonomic dysreflexia is something that people tend to get quite confused about. Autonomic dysreflexia occurs in patients with complete spinal cord injuries. And I appreciate there are people who will argue that it might happen in some of the severe MSs and some evidence of some of the brain conditions, but I'm going to talk about it in relation to spinal cord injury. What happens is if you get a painful stimulus below the level of the region, you get a significant increase in sympathetic outflow below the level of the lesion. Sympathetic outflow causes vasoconstriction. Vasoconstriction, if there's enough of it, causes severe hypertension. And when your injury is at the level of T6 or above, that vasoconstricts your splenic bed. And that means you get a lot of blood being dumped into the system with very little ability to counteract that above the level of the lesion. This is an emergency. The patients get headache, severe hypertension, flushing, bradycardia, and they can actually die, and they can get mini strokes. So you need to know about this. The biggest trigger of autonomic dysreflexia in this group of patients is bladder distension. It tends to be the blocked catheter, but also if you're doing something urological. So if you're managing patients like this, you need to know what autonomic dysreflexia is, you need to know how to manage it, or you shouldn't be managing them. So I don't have enough time to go through the full management of urological problems in neurological patients. So I've put together, if you like, a summary of what I think you should know. You should know how to assess your neurological patients as per the NICE guidelines. And by that I mean who is at risk. So you need to understand bladder safety. You need to know your red flags and refer appropriately. It's good if you've got pathways. Liam's going to talk a lot about that. It's very useful if you've got pathways to put people through. Always think about conservative options. Really important is bowel management, because if you've got bad bowels, your bladder's not going to work properly no matter what you do with it. Medical and surgical options and neurological relevance. Bladder overactivity options for managing: conservative, anticholinergic, beta-3 agonists, intradetrusor botulinum toxin, neuromodulation, and cystoplasty. And for stress incontinence, always think about conservative options. Make sure they're emptying their bladder properly. Do they need to lose weight? Smoking reduction. Pelvic floor exercise is very important. And then we have surgical options, which I'm not going to talk about. However, I am going to just mention an artificial urethral sphincter. So this is a line drawing of it on the right-hand side. We have to be careful about pictures we put up these days. But essentially, an artificial urinary sphincter is put into men and women for stress incontinence. It's used more in men because women have more surgical options for stress incontinence. It's usually made of silicone. There is a cuff that sits around the urethra. It fills with fluid, and that fluid stops the leakage. You have to pump the fluid out of the cuff to allow yourself to wee or to pass a catheter. And it's really important that if you're managing patients like this, if they have a sphincter, first of all, you know that it's there, and secondly, that you don't catheterize them unless you know what you're doing. If you're going to put in an indwelling catheter, you need to deactivate the sphincter. It's actually not difficult to do, but if you've never done it before, it's quite difficult to do. But what you can do is, and most of these patients are very well educated on how to manage their sphincters, what you can do is you can pump the pump, which will deflate the cuff, and then you can just pass an intermittent catheter and take it back out again. And obviously then ask for some specialist help. So that's the end of my presentation, and I'm going to pass you on to Liam, but thank you very much. And any questions we will try and address at the end of the presentation.
Thank you very much, Sheila. And I suppose next it'll be Liam giving the nursing perspective and share with us your experience with a nurse-led clinic evaluating urinary symptoms in MS patients.
Hi, I'm Liam Rice. I'm a multiple sclerosis clinical nurse specialist. I've worked in the area of multiple sclerosis for many years. But my background was in neurology, hence why I've given myself this fancy Euro lead title. No one's actually given me it. I just put it on myself because I thought it was appropriate. So there we go. My objectives are to talk about urinary assessment, history taking, bladder diaries. I'm assuming that I looked at the list of delegates, and there's a lovely mix of people from different backgrounds, and I will try and not focus too heavily on MS, but that is my area and that's what I tend to do. But I think a lot of the assessments come and are based on practice that we all do probably whenever we see any patients with bladder problems. So a lot of the things you will be familiar with, I hope, and some of them you may not have thought about, but maybe you'll go away with some ideas and hopefully some questions as well. So I'll be looking at the pathways that we manage urological symptoms and a discussion around conservative management and importance of bowels. And if I've got time, I've got a case study, but only if I've got time. Okay, so assessing your patient. So obviously this is the first thing that we do. This is the first contact. Excuse me. When I see a patient in clinic, I'm looking at the clinical course, particularly with patients who've got history of urological issues and neurological issues. For example, with our patients who've got multiple sclerosis, I want to look at progression. Have they come to clinic perhaps with new symptoms that may be indicative of progression within their condition? So that might lead me to think about repeating an MRI scan to see if there's been any changes. A lot of patients with MS, for example, often don't develop bladder problems and bowel problems for quite a few years after diagnosis, sometimes 6 years or so. There's quite a lot of study on that, but some people present with bladder problems, and that bladder problem might have presented years ago, and they might, for example, gone to see their GP, who maybe put them on an anticholinergic drug to relax the bladder a bit more and help them with urgency, for example. That may actually have been the beginning of the neurological condition. So always consider that when someone presents with neurological issues, it may be neurological in nature. So always consider that. Things like, sort of changes within their other health conditions. Are they, if they're a gentleman, have they, of a certain age, have they had a PSA checked? Have they got any other urological conditions? Gynecological conditions, of course, if it's female, and anything that you think might be indicative of changes. Regards to the sort of clinical history, the actual lower urinary tract symptoms, or the LUTs, as we sort of call them, are which I'll talk about in a bit, a little more detail. Have they changed as well? Sexual function, really important and often missed out because it's something that is a bit difficult to talk to patients about as a nurse, and also difficult for patients to talk about as well, but really, really important to get that in, because obviously, as Miss Reed said before in her excellent presentation, that a lot of the nerve pathways from that feed the bladder, the bowel, and sexual organs are all relative. If suddenly a patient's developed odd sensation, perhaps in the saddle area, as we call it, it may be indicative that there might be something else going on neurologically. So really important to open that part of the conversation up if you can. And I've got better at it because I've got older and I'm less shy, if you like, about it. Medication is obviously very important. Use of prescription drugs, diuretics, of course, which can increase urine output, antidepressants, antipsychotic drugs, which can cause problems with retention and exacerbate symptoms. So they're all things. And of course, Sheila's has mentioned ketamine. As you know, it's or you don't know. I mean, depends. Particularly in England, it's quite epidemic at the moment. Really, with a lot of younger people, always bring that up if you feel somebody might be using it. Ketamine, it causes inflammatory changes to the urothelium, and it's cheap and it's very available and it's nasty and it causes a lot of people a lot of pain. So I always try and bring that up. And then bowels, again, I'm going to talk a little bit more about that in a few minutes later on, but very vital to get that in. So what are lower urinary tract symptoms? I'm be wrong to assume everyone knows all these things, so I'm just going to go through what I think are the basics, and I think it's good to go back and just look at all of these symptoms. So urgency, frequency, urgent incontinence, hesitancy, urea, nocturnal polyuria, stress incontinence, and post-micturition dribble. So urgency is the need to pass urine without much warning, as I'm sure most people have maybe experienced themselves, but always, so if you can guide people with these questions so they understand what that means to them. Frequency, needing to pass urine very often, more than 7 times in 24 hours. There's different variations on that, but some people are, oh, sorry, I've got a bit too fast here, haven't I? Sorry. Anyway, it doesn't matter. Hesitancy, not passing immediately, nocturia, they need to pass urine at night and pass in larger amounts. Stress incontinence, which Sheila mentioned earlier. Again, just asking simple questions like this. And post-micturiation dribble, it's not just men who get it, women do get it as well. And we've got some good techniques that we can show, particularly men, how to manage that. So there's a number of things that I ask in the initial assessments. So fluids, really important. The slide on the left has brought many a disgruntled patient who mainly just drinks tea, especially in where we are in Sheffield. A lot of people in Yorkshire like to drink tea. It's got to be Yorkshire tea, apparently, and nothing else will do. And it's usually caffeinated. And when I tell them that they're better off drinking decaffeinated, it's like I'm giving them the worst news ever. And they face drops and they look at me with this absolute disappointment. But I always say, try and reduce your caffeine, try and reduce fizzy drinks. All of these things will irritate your bladder, and if you can switch between a caffeinated and a decaffeinated throughout the day, if you habitually always drink tea or coffee, you can see, and I have seen people have quite a significant change when they have followed some of the guidelines. Certain foods can irritate your bladder, such as chocolate and tomato sauce, and avocados, fruit and apples. I mean, all this stuff, we all tell people to eat more healthily, and they can irritate bladder. Spicy foods can as well. What's not on this slide, and I do apologize, is I put the wrong slide on, but it does say to try and aim to drink between 1.5 to 2.5 litres a day. Some people might argue that, but I always say 2 litres a day if you can. That's the optimum amount. That's what's required for our bodies. And dehydration scale with the diagram there shows you different colours of urine. Always good to look at if you're doing your assessment. Just have a look at it. Is how concentrated is it? Obviously, sometimes we can see different shades, particularly if you've been eating beetroot, for example, which is if you have done and you've forgotten, it could be quite a shock till you realise that your urine's red because you've been eating beetroot. So, but it could also be indicative of other things, of course. So bladder diary. So this is just an example of many that are out there. I use this one on the left. I find it really helpful. I've been sending them out before the appointments to try and get people to fill them in. A 3-day diary. This is one that I pulled up from the other day. I know it's quite difficult to read, but it's getting patients involved. It's giving us as much information as we can, trying to determine what fluids they're drinking, trying to determine when they go to the toilet. So it's telling me on this one, for example, I think I counted it earlier on, I think she's going, what is it, 1 2 3 4 5 6 7 8 9 10 11 12 13 14 15 odd times a day. That's quite a lot. 3 times in 1 hour, in the space of 2 hours, sorry, in the space of 1 hour. And this lady who is actually was retaining urine as well. I did another bladder scan on her, and she actually was emptying her bladder. And now we've got her on anticholinergics, and her bladder's much more settled. But the other problem that she had, which we didn't, which is why bowel assessment is really important. She wasn't emptying her bowels, so now she's got her bowels more regulated. Her bladder's settled as well, so good outcome. So it's a good indicative tool to use. It gets the patient involved and gets them thinking a bit more, I think, about what they're drinking. So that's not a bad thing. Try not to be judgmental with people and say we're not trying to make you feel bad, but it just helps with getting a good measurement tool. So also I've jumped around a bit. So bladder scan. Bladder scans crucial, very easy to do. A lot of centres have got them. I know some centres haven't, but these are sort of bladder scans are like our bread and butter in our bladder clinics. So simple, easy to use, very, very, very good. These scanners, this is one of my scanners which we've got. These are 3D scanners. Anyone who's been knocking around for years will know that, you know, the old scanners were okay, but these are just fantastic. Give you a really good readout. Excellent for doing pre and post scans. And the printout, there's a little printout on the right of the screen from a scan I did a few weeks ago. You just aim it at the pubis, just above the pubis bone, and you get a good image. And it's always good if you, particularly with patients who've got high residuals, particularly with neuropathic patients, of course, that you repeat that and don't just go on that one scan. And I'll talk a little bit about the pathway about that in a minute. Okay, so just a quick checklist. Now, this is an old checklist because everything now that we do is electronic. So again, I'm sorry about the poor quality, but you can see on the left-hand side is the lower urinary tract symptoms that I've ticked, and then on the lower box I've asked the person about their bowels, and they've said they're constipated, they use Senecot, you know, the sexual function, they've got reduced sensation, etc., fluid, diary, a bit of about their diet as well, and also just some information. And this information is really good because I might need to forward this person on to my colleagues in neurology for some further investigations, and I will attach this so they can see it. And now it's all electronic, everyone can see what we're doing, but it's just good to get as much information and have a good checklist to help and guide you. So urinalysis, obviously very important within managing patients' bladders. We do see a lot of bacteria, and a lot of bacteria is often treated. It's not widely accepted. There's no widely accepted definition of what constitutes a UTI in people with neuropathic bladders. It does variation in care often leads to overuse of antibiotics, and I think that's quite true. We would define a urinary tract infection as 2 or more UTIs in the last 6 months, or 3 or more UTIs in the last 12 months, and that's from NICE guidance, and that's something that we use for our practice. But because of patients with neuropathic patients, particularly patients I look after, MS patients, as you may or may not be aware, this is a really important thing to take. If you've got one thing to take home from my rambling talk, is that patients with MS do not do well with infection. That will often cause a pseudo relapse. A lot of our work is about patients having exacerbation of symptoms, and a lot of them are brought on by urinary tract symptoms or bacteria in their bladder, and we try really hard to manage them. And I'll show you some of the work that we do next. So just little bit of what goes on in a dipstick urine. If you've not done one, maybe you haven't, or maybe you do it differently, but that's the guidelines, and the ones we look at generally are nitrates and leukocytes to see if there's any signs of infection. And of course, I always look at specific gravity, gives me an idea of the concentration of the urine, and of course protein, etc. So I'm not going to spend too long on that because that's a big subject. But please just remember, if you do about patients and infection and how it can affect neuropathic patients. Okay. So this is a pathway for overactive bladders. So on the left, we've got what I've just talked about. So taking a history, input, output, bladder diaries, fluids, checking their post-void residuals, their bladder scans, checking the urinalysis, checking their blood, seeing that there's any changes with their blood, particularly with the kidney function and liver function, etc. If you might want to check their coagulation as well. If you're thinking beyond that, this patient might need a suprapubic catheter, for example. Bowel assessment, which I'll look at in the next couple of slides. That's my review. Then if the patient then is, when I do a bladder scan, if their residual on the bladder scan is more than 100, like I said earlier, I would repeat that a month later if I could, whatever's possible. If they're still having large residuals, I would then consider intermittent self-catheterization, and we would arrange for that to be done in the community. That's what we do in Sheffield. Sometimes I'll teach people in clinic, but it's not always the best place to do it because of time, and patients will be probably better and will take it on board better if they're doing it and being taught how to catheterize in their own home than over their own toilet, for example. They're more likely probably going to have a better outcome. If they have residuals below 100 mils, we can commence them on an anticholinergic drug or a beta-3 agonist. We sometimes use them drugs together, and those drugs very quickly would be solifenacin, trospium, and then the beta-3 agonist drugs will be mirabegron or new one, vibegron. You can use them together, and it's good to have a drug that's not cholinergic because of cholinergic burden, especially in older people. There's lots of links, as you know, to dementia with cholinergic drugs, and the cholinergic burden can often be just overlaying if you put another drug on top. So to use something like vibegron is good, or mirabegron, and we could, like I say, use them together as well. That really helps. Also, double voiding is really important. That's just a simple technique of having of going to the toilet and then getting up as if you're going to leave and then going back and having another wee. That sometimes gets the urine out. Just a little note about caution: if you're self-catheterizing and you use a mirabegron, I had a few cases where patients were struggling to get the catheter in, the mirabegron working a bit too effective. If those are not working, if the patient is still having very overactive bladder, at the detrusor of activity, not getting on, or the tablets aren't working, the next step would be Botox into the bladder. Again, if they have Botox into the bladder, they need to be able to self-catheterize because there's a high risk of them going to retention. And actually, a lot of people become quite independent with Botox and ISC. It gives them more confidence, gives them more control. We would do, as Miss Reed said, with ultrasounds. These are things that might be done following on. Ultrasound, flexible cystoscopies, would consider suprapubics, video, urodynamics, even neuromodulation, and other urological intervention. I'm very lucky in Sheffield that I work with such brilliant urologists. I can send my patients to them. I run a clinic every month, and I can we can join together with patients that I've not been able to, that the pathway has kind of led me down to a clinic. And also, forgot to mention also pelvic floor, which is another big area that we sometimes do, but we can refer to physios as well. Okay, so UTI, I'm just aware of the time. UTI pathway. So patient is reviewed in clinic. I'm not going to go through that again. I've already mentioned that. And we've got a UTI information sheet, so which I'll show you next, but that has got information on self-care, prophylactic antibiotics, D-manus, Hiprex, estrogen cream. And beyond that, I would consider then referring them to the joint clinic or asking the urologist to do flexible cystoscopies, ultrasounds. And then there's also intravesical treatments that we can use as well. So the UTI information sheet, we send this out, we send it to GPs, to other healthcare professionals. I'm more than happy to share it with you. And I give it to the patients, and it's to try and avoid using antibiotics. We try and use a stepwise approach to management, and that includes D-manus, which, if you don't know, is a treatment that's a food-based, so it's not on prescription, and it helps by sticking to bacteria and stopping the bacteria sticking to the bladder wall. We use Hiprex, which is a antiseptic, if you like, urinary antiseptic. Creates formaldehyde, which kills bacteria, and you need acidic urine. So vitamin C, you take vitamin C with it to help with that acidity. Estrogen for women, estrogen cream helps really well at postmenopausal women. Estrogen levels drop, so it helps with that. We then would consider installations, vaccines, also looking at the catheter management if patients have got a long-term cathetering. And this is a good place to start. And I find that some people are finding really good benefits from mixture between, say, Hiprex and the estrogen, or even all three. But it's an ongoing, it's always quite a problem with UTIs, like because of the, I think people using, because of the way bacteria affects particularly MS patients. Neurogenic bowel, I've got a slide on this just because this is another big area, but really important to be aware of patients' bowel. Not only are they very, as you can see on the slide on the right, very close to each other. And that lady I mentioned earlier, who'd had problems with incomplete bladder emptying, which was in fact, we think, probably more down to her bowel being very, very backed up. She was using transanal irrigation, which I'll show you in a minute. But just dysfunction of the colon, constipation, fecal incontinence, all down to sensory motor control. And then some of the ways that we do in bowel management, she's using the Bristol stool chart, but the standard bowel management here in the triangle, diet, fiber, supplements, laxatives, and then thinking about transanal irrigation. And there's one here on the right, which is called peristeen. I'm sure a lot of you may be familiar with it. It's a really, really useful way of controlling and activating a contraction of stool, of defecation. And these are all things that I will spend time talking to and managing patients with as well. And then very quickly, I'm sorry I'm running out of time. My pathways, there's the pathways that we use. I haven't gone through all of them because I'd be here till next Tuesday talking about them, but they're basically the ones that we use, and they're all really the really successful way of managing conditions, and all the referrals come from the neurologists, and they're all triaged and they're all assessed, hopefully, and then all reviewed back in. So all our patients get a good review. And that's it. I'll stop talking. Thank you.
Brilliant, fantastic, Liam. Thank you very much for taking us through a practical approach to assessing and management neurogenic LUTs. Now, this is a session on when brain meets bladder, and we are now going to hear about the neurological perspective and invite Shiva Nair to actually take us through that aspect of it. Shiva.
Thank you, Jalesh. And thank you, Liam and Sheila, for your lovely lectures. I will be covering, as Jalesh said, about the neurologist perspective. Well, the neurologists by default are like sniffer dogs. We like to sniff out the causes, what is causing the problem. May go to long lungs, any lungs, to find out what is the underlying cause of the problem. And that need to be tempered here with the pragmatism. In the next 15 to 20 minutes, I will try to cover these aspects, that is the urological presentations of neurological disorders, impact of the urological issues on neurology, and the impact of the neurological problems on continence. So let's start with a story. This is a 40-year-old lady who has multiple sclerosis. She condition has been fairly stable. She has spasticity, lower limb weakness, walking with Zimmer frame at home. Since a couple of months, she has been experiencing increased spasms, stiffness, and pain in her lower limbs. On examination, the spasticity grade 3 in both lower limbs, and she has about 3/5 power. So what are your thoughts about the possible diagnosis here? Why has she got worsened? The most obvious diagnosis, response I get is that, okay, she has a progressive MS, this is a part of the disease progression. So if you think a little bit beyond it, actually what caused this lady's problem was she had a normal she had an MRI scan which did not show any new relapses, scan of the spine, again, no new lesions. And what clinched the diagnosis was the MRI of the spine, lumbar spine, and then this was her problem. She had calculi in her bladder. So this has resulted in increasing spasticity. After my urology colleague sorted out her bladder problems, her spasticity came down and she returned back to her baseline. So when we think of, obviously you don't need an MRI scan of the whole brain and spine to diagnose a bladder calculus, but we neurologists do need that. So we need to think of urology problem when you are faced with a deteriorating neurological condition like MS or people with spinal cord injury or So this is another story. This lady had a slightly longer history. The 65-year-old lady presented with initially with back pain radiating to the right leg, urgency and incontinence of urine. So she ended up in ortho. They did an MRI of the spine. They found an L5S1 disc. So they did this surgery. Her pain improved, but her bladder symptoms continued, and she continued to develop problems with her left leg. And then she progressed, developed pain and stiffness of the left arm. So the orthopedician repeated her MRI scans, including cervical spine, no issues. She had some degenerative changes in the left shoulder, so they did some surgery for her left shoulder. Unfortunately, she continued to get worse. Then it was subsequently referred to neurology. By that time, she was sitting on a wheelchair, poor balance, recurrent falls, feeling depressed. On examination, she has rigidity, slow speech, and postural hypotension. So what was the problem here? I think her problem, the diagnosis here, this is what her MRI scan showed. So if you look at it, she has hot cross bun sign in the brainstem. So this lady has a multi-system atrophy, which is well known to present with bladder problems. She incidentally had a disc, which may have given her some back pain, but that her diagnosis was delayed, and she has to undergo a couple of surgeries before the diagnosis could be made. So the bladder problem could be the presenting manifestation of not just a spinal cord issue, but or it could be a presenting manifestation of some of the brain problems. So when you think when they're presenting with bladder, you need to consider issues like pneumopressure hydrocephalus, multisystem atrophy, frontal lobe tumors, and maybe anti-communicating, cerebral artery strokes. So then what is the impact of bladder problems on neurology? So can get bladder infections or stones or incontinence can cause skin breakdown, and this can worsen the neurological symptoms like spasticity or mobility. It can also result in recurrent hospital admissions due to delirium, and as Liam has mentioned, in MS patients, this can cause pseudo relapse. So when people present with these symptoms, we need to consider the possibility of an underlying urological cause for this neurological deterioration. And then the effect of the treatment of bladder problems. One of the common things that urology colleagues use is anticholinergics. The anticholinergics, acetylcholine is required for memory. This is one of the neurochemicals that get depleted in Alzheimer's disease. So it's not surprising that one of the side effects of the anticholinergic medication is to worsen the cause cognitive problems. People who are taking anticholinergic drugs for a long time are at higher risk of developing dementia, and they can also present acutely with delirium. So we could calculate the anticholinergic burden using the anticholinergic burden calculators. Some of them are available free online, and if they have a heavy anticholinergic burden or they have an underlying cognitive problems, we need to consider alternatives. Now there are various other alternatives for anticholinergic drugs for controlling overactivity of the bladder. The neurological impairment as such may have an impact on bladder, even if there is the disease itself is not causing a urological problem. One is the reaction to the feeling of bladder fullness may be a bit slow, and this may result in incontinence. Then again, the neurological problems can cause problems in mobility and transfer, like due to ataxia or weakness. They may not be able to access toilet in good time. The intermittent self-catheterization requires good control of the hands, and the person need to be able to sit and separate the legs. So if they have significant adductor spasticity or poor trunk control or incoordination of the hands or weakness of the hands, they may not be able to do the intermittent self-catheterization. So they need to be trained on how to manage the bladder in these situations. Which include timed voiding and fluid regulation, all those techniques that Liam has mentioned in his eloquent lecture. The drugs that we use to treat neurological symptoms can also have an impact on continence, like antispasticity drugs can sometimes cause incontinence, especially baclofen, gabapentin, diazepam, and dantrolene due to, they can cause a bit of weakness of the perineal muscle, subtle weakness, which may be a bit too much for a person with an underlying neurological urological issue. We use botulinum toxin for treating both spasticity and the bladder problems. So if the person is receiving both treatments, then we need a good system of communication between the neurology team and urology team regarding the dates and type of injections and the type of the toxins used. Intrathecal baclofen pump is again used for treating spasticity. It can have an effect on bladder. They reduce the detrusor activity and sometimes can cause urinary retention. So neurology and urology are need to be in balance. So it's the neurology can directly affect continence, as in spinal cord injuries, multiple sclerosis, pneumopressure hydrocephalus, etc. And then the neurological symptoms can affect continence, like spasticity or weakness can interfere with continence and maintaining hygiene. Hand problems can impact continence, and urinary issues can exacerbate neurological symptoms or cause new neurological symptoms. So they both need to, we need to consider them not as two separate specialities, but as we need to consider the whole thing as a holistic problem. I will briefly touch upon this problem of scan negative Koda-Equina syndrome. As we all know, Koda-Equina syndrome is usually due to, is classically described in lumbar disc prolapse causing compression of the Koda-Equina, but the scans are in majority of the patients with so-called Koda-Equina syndrome, the MRI scans are negative. So we find discs in protrusion causing Koda-Equina compression only in about 20% of them. In 10% of them, it's due to other neurological causes, and in 2/3, we'll never identify a definite pathology. So if the scan is negative, there are a host of other conditions that can produce scan negative Koda-Equina syndrome. So if they have perineal pain or a sensory level, progressive weakness, loss of reflexes, we need to look for an organic or a structural cause causing this. There are a long list of conditions varying from inflammation, infection, vascular, all causing this problem. Then if we exclude all that and still the person is positive, this is a type of functional neurological disorder. These people usually have associated mental health issues like anxiety or depression, post-traumatic stress disorder. Some of the clinical clues are the distribution of the symptoms. Their pain may stop at knee. They may not follow a dermatomal pattern. They may have a recent increase in taking their pain medication. They may report loss of perianal sensation on examination. They may have panic symptoms like palpitation, sweating, shortness of breath, etc. They get a feeling as if the leg's not belonging to them, tingly sensations outside the area of Koda-Equina, like around the mouth or in the fingertips, patchy sensations elsewhere in the body. Clinically, their reflexes will be retained. Hoover's sign will be positive. Johnstone in his work on functional Koda-Equina syndrome has mentioned that the saddle numbness, residual urine, and anal tone may not help in diagnosing this condition. So how do you manage the scan negative Koda-Equina syndrome? The one is to validate the symptoms. We need to ensure the patients that we are taking the symptoms seriously. We need to express the distress the symptom is causing to them, and this is a valid symptom and it is valid to have that distress. And that explanation need to be given to them. The patients do accept that there is no structural cause for it, but this is more due to a functional cause, and there may be an underlying psychological problem which is driving it. A surprisingly large number of them do accept this. We need to ensure that the bowel management is optimized, and if the bladder requires catheterization, we shouldn't leave them on a continuously draining catheter, but do a flip flow and attempt to take out the catheter as early as possible. It also provides psychological support. So in summary, the bladder and the neurological symptoms are closely intertwined. Neurological conditions can present with urological problems. Primary urological problems can exacerbate or make neurological symptoms worse. Then people with functional neurological symptoms can have bladder problems. So when, as a neurologist, when we face with this kind of a problem, we need to consider both neurology and the urology together. It's highly unlikely for a neurological problem to present with only isolated bladder symptoms. If somebody presents and everything is negative and we come across them, we need to make sure that there is no underlying urological cause. Thank you.
Thank you very much. And do you want to stay on? And Sheila and Liam, if you want to come back in or just turn your videos on, the cameras on, we have plenty of questions to take us through. I did wonder, Shiva, regarding the yin and the yang. Which is yin and which is yang? Or maybe should we leave it as a rhetorical question, maybe?
Yeah.
Yeah, they're closely intertwined. I won't say the urology is the dark side.
No comments.
No comments. Right, let's move on. Look, we've had several questions on UTIs, and Sheila, do you want? And they're all quite interlinked. Do you want to maybe answer some of those questions, perhaps?
Yeah, no, I'd be really happy to. And I've noticed that. I think at least half our questions have been on UTIs, and I cannot give you guys a full lecture on UTIs. So I'm just going to say a couple of things. There is two excellent, nice guidelines, which I think we can send off to you the links later on. To all the delegates. One of them is on recurrent urinary tract infection, and one of them is on infections associated with catheters. The recurrent urinary tract infection guidelines are not specifically for patients with neurological conditions. And I think it's really important to remember that, but they're really also very useful. Because somebody asked, one of the questions they asked is how many infections do you have to have for that to be a recurrent UTI? And the absolute black and white answer is 3 in a year. But I just don't think it's as simple as that in a neurological patient. So the couple of things I would say specific to these patients is, number one, do they have a UTI? Okay, because a lot of them have symptoms. Liam mentioned bacteria. Bacteria, if it's not symptomatic in a catheterized patient, is not an active urinary tract infection. And you have to be very careful about that you assess them properly, that they're not just given antibiotic after antibiotic. There's a couple of questions in there about spinal cord injured patients that are really complex, and there's two questions, and those patients need proper urological assessments. I mean, they need at least a cystoscopy, probably under anesthetic for the C2 tetra. They will need upper tract imaging, possibly even a CT. So when you're getting to those complicated patients, they do need specialist input. Those patients should be under urologists for that. The only other thing I would say is it's such a big topic, and no matter what talk I do, everybody asks about this. Would the Neurology Foundation consider putting on a UTI webinar? I think that might be something to think about. There's so many more answers I could give, but I'm going to stop there. I won't be able to answer anything else. So.
Gauging from the questions, I think that's really an area of need. There was a question on cranberry capsules. Are they useful to prevent UTIs?
Some people think so. They did do a big they did do a big evidence search of this, and they didn't feel it was particularly useful. So I honestly don't know the answer to this. I think NICE don't recommend them as a, that you should use them, but I have had patients swear by them to me, so I don't feel very strongly about it. I don't routinely recommend them. What do you do? What do you guys do?
Well, you're right, isn't it? Because the original studies showed that there was a benefit with cranberry extract tablets, but then the randomized control trial multiple sclerosis proved to be negative. But it is quite anecdotal. You do see patients who
Yeah.
actually respond well. It's much more cheaper than D-Manos. So you get it from all the health shops. Liam, your experience?
Yeah. I mean, people will come up and tell me that that's what they use. I would say carry on with it if it's working. But we have used Demanus and Hiprex in my practice. I've seen quite a lot of changes with that. But I think it's totally relevant to use, cranberry, definitely. Yeah.
Well, there is another question about vaccines for UTIs. Is this a new thing? Is there any evidence for neurogenic patients?
I'm not sure there's any evidence for neurogenic patients. I mean, vaccines are not licensed in the UK for use. However, there is proper randomized controls in non-neurogenic patients, and it's in the European guidelines for recurrent urinary tract infections. We have them on a named patient basis. It's only under specialist care. You'd only get that in urology named patient basis access. I'm not convinced they work particularly well personally, but
Thank you. Shiva, we have a few questions about anticholinergics and the elderly and anticholinergic burden. So, do you look at the anticholinergic burden when prescribing medications for LUTs? So,
Yeah, yes, the anticholinergics, especially in people who have an underlying cognitive problems or a bladder issue, which is fairly common, to be honest, like people who with MS or elderly with spinal cord injuries. We are seeing more and more people with elderly people in whom the spinal cord injury is kind of a marker of a dementia. So they do get confused when you start them on anticholinergic drugs. So I now tend to veer more towards mirabegron or vibegron trospium side rather than go for a conventional anticonvulsant anticholinergic when I deal with especially vulnerable people with loads of lesion load in the MRI scans in MS and those with spinal cord injury and cognitive dysfunction.
and is it a case that you just of eyeballing that you look at the prescription and then mentally sort of deduce that okay, it looks like the anticholinergic burden is high, or do you
Yeah.
ever use a formal scale in your practice?
Yeah, there is a online free anticholinergic burden calculator. So you put the name of the drug in it, the score will come up. So a score of about 3 means anticholinergic burden is high. So you'll be surprised. There are many drugs which we may not kind of think of anticholinergic having an anticholinergic side effects, but which contribute to that score, which are not used as an anticholinergic as such. So this is the one. Yeah.
I just thought I'd just quickly show it rather than trying to send the link, but I can send the link as well. Okay.
And Liam, how do you use this in your practice? Is it something you just show the patient, or do you get?
If I've got time, if I've got time, I'm looking through the meds before they come in anyway. I mean, that's part of my assessment, as I was saying earlier on. So I would try and use it while they're there, make sure that I've got all the medications correct. And I will use it. And it's very sensitive, though. I don't know about you, Steve. I find it quite sensitive to it. You can put in, it will alert you. But it's good. It's a really good tool. But I think there's another question that I spotted, if you don't mind me just jumping in, about anticholinergics and falls risks, I think it was. I mean, I tend to, if I can, use mirabegron or vibegron if I think it might increase the cholinergic burden a little bit more, especially the amitriptyline, which a lot of our patients are on for pain management. So it's good to have a variety, isn't it, of medication? But I tend to use it. Yeah.
All right. And a question for Liam: is green tea without caffeine a good alternative?
Green tea is not good at all. It's awful. Sorry, it's terrible. It's the worst. It's disgusting. No, sorry. Peppermint tea is much nicer. I would say anything. I mean, green tea. I think, am I right in thinking it's like the original tea? It's the kind of origin of tea, isn't it? And it's really nasty and very strong. But I think decaffeinated. Yeah, anything with decaffeinated, it's great. And I always say to anyone, like, I'm just repeating myself, I know, but if you're so into tea and the idea of coming off tea, it must be like giving up cigarettes or something. You've got to graduate yourself off it. But the difference it can make is quite significant, I think. And I've seen that a lot with people who actually stick to it. Yeah. But yeah, if you need to drink green tea, drink decaf. Yeah. But my advice is just get rid of it. Yeah, it's awful.
Good messaging there.
Yeah.
We have a question on urine analysis, urine dipsticks. It's like Marmite. Either you have a group that loves it, loves it
Yeah.
or hates it. So
I saw that question
yes.
actually, and I agree with the person who sent the question. I think you've got to be very careful about doing lots of urinalysis. They can be really unhelpful. I think you need a reason to do urinalysis, and not in catheterized patients. They're just not helpful at all. So I don't use them very much. I think if I'm asking a question, I would use them. I think if somebody's got new symptoms and they've got no catheterization or don't catheterize themselves, then yes, I would use them. But I agree with the sender.
Fantastic. All right. And we have a couple of questions on PVRs and initiating
Yeah.
catheterization. So if the patient refuses intermittent self-catheterization and the residual remains above 100 ml, how frequently should you recommend repeat bladder scans to monitor for the retention? Maybe we'll start with you, Sheila.
I mean, I think that's a great question, actually, and I actually don't have a proper answer for it. But there's just a two thing to say is, I mean, why do we say 100 or 150 mils is a residual? And there's one question at the end asking for the evidence for 150 mils. I don't think there is any evidence for that. I know you're one of the authors on the Neurogenic guidelines, Gillette, and I know you've moved it from 100 to 150 as the recommended residual, which I think is a really good idea. But I was on the original panel for the 100 mils, and I remember there was no evidence for it. And Professor Fowler, who is one of my all-time heroines, she was leading the group, and she actually said, after we'd all had a big argument, she actually said, I'm the one who knows most about this. We're putting 100 mils in it, so we put 100 mils in. And it was definitely its expert opinion. I think the important thing about post-void residual is what is functional residual capacity and what are the symptoms of the patient. Because if you have got a bladder capacity comfortably holding 400 or 500 mils, actually leaving 100 mils isn't a big deal.
Okay.
If you've got a bladder capacity of 200 mils, leaving 100 mils is a big deal. So I think you have to be careful. We have to, when we do guidelines, we have to put cutoff somewhere. So I'd be interested to hear, Jalesh, how your guidelines came up with 150.
Well, once again, I think, so many years after that initial sort of panel that you were involved in, the evidence hasn't become available actually to define what the PVR is. What we know is that with the neurogenic bladder, of course, it's a smaller capacity compared to a non-neurogenic bladder. So generally the PVR, your threshold for initiating catheterization is going to be lower. At the end of it, I think it was really based on other guidelines that we really came up with that. And it was a much more formal way of a Delphi consensus. So we had a soft touch approach to getting a consensus, and everyone was happy with 150 ml. But you're right, it isn't a single value that's important, and I think you'd want to repeat the PVR to check that it is consistently elevated, and it is the functional bladder capacity that's important there.
And I also think it's important, I always discuss my patients as to why, if you've got a post-void residual which is asymptomatic, the reasons for getting your bladder empty are if it's putting your kidneys at risk for the reasons I've talked about, if you're having other problems such as you're more incontinent, you're getting infections, you're getting stones. And actually, if you're not getting those problems, if you're properly monitored, then it's perfectly reasonable to choose not to empty your bladder. So it's about understanding it and making the right choices. And how often you check them, I honestly don't know. I would say at least every year, or if they're symptomatic in the meantime. But I have plucked that out of my head. So, but that's what I would do with my patients.
And I would add as well, Sheila, it's really important to talk about their diary as well alongside those figures. To give a good, good overall view. Yeah.
Yeah, but they're great questions. They're exactly the questions we ask that we don't know. So.
And Shiva, if you're sitting in a neurology clinic and if you come a patient with who's got a borderline elevated PVR, would it be a similar sort of a follow-up that you'd suggest?
Yeah, I think like again, it like Sheila said, it's more a proportion rather than absolute values about the PVR, and we will. I agree. What if there is an issue, I actually send them to Liam. He's my go-to person. I have the luxury of him
I noticed.
sitting in the next room.
All right, brilliant. Well, our speakers have said that they can stay back for a few minutes. It's great, so we can maybe just go through the questions. So there's a question on vaginal estrogens, and should we recommend it also in the elderly or frail, or is it mainly for people who are still more likely to be having regular sex? Maybe is that one for Sheila, perhaps?
If we're talking about recurrent urinary tract infections, yes, all postmenopausal women, it's this proper randomized controlled trials which shows its efficacy to decrease the risk of recurrent urinary tract infection, and there's proper science behind it as well. So, if postmenopausal ladies getting recurrent urinary tract infections, vaginal estrogen cream is one of the mainstays of management, even before you consider, prophylactic antibiotics or methenamine hepurate.
Right, thank you. A question for Liam. A person living with dementia, unable to control the release of urine and feces, even on a good toilet regimen. Is there anything that you can help drug-wise, or is it all about the brain signals being damaged? So start with Liam and then maybe Shiva.
Good question. Big question. I think you just want to. Not sure whether what kind of assessment's gone on, whether we've done all the bowel and bladder assessment. Are they on laxatives, or are they on anticholinergics or beta agonists? I'm not as familiar with dementia as I am with MS, but I imagine there's a very similar outcome in terms of what we could do. So I would go through the bladder and bowel assessment that I alluded to earlier. And there may well be a better way of managing things like transanal irrigation is quite good because you can empty someone's bowel with a bit more control. Or might be one way, and maybe think about some beta agonists for the bladder.
Right, Shiva, medication-wise, do you think it works?
Unfortunately, the effect of medication on people with brain problems. That what I meant is about the pontine maturation centers problems above it is, in my experience, it is not that good. It's more to do with scheduled avoiding dementia. It is a big problem, and mostly we end up giving them pads, to be honest. Yeah, and keeping them because they don't tolerate catheters well. They pull it out. It's a difficult scenario, unfortunately.
Okay, thank you. We have a question about trials without catheters. So I have seen a long-term catheter left in situ after an acute admission, which causes issues with TWARCs. Any comments? Maybe Liam? And then Sheila?
Yeah, I'm just reading that. Sorry, I didn't catch what I was looking at. An email I had. Sorry about that. Yeah, switch up to acute admission. I don't know. What do you think, Sheila? I mean, I have had people come in with catheters in that. I'm almost, why you've still got it in? Not quite sure,
Yeah, I'm not entirely sure of the question. I mean, I certainly think that everybody should have a plan if they're being discharged with an indwelling catheter, and if nobody should be discharged with an indwelling catheter who doesn't need it. If I may not slightly answer the question, but there's one about suprapubics versus urethrals. So, just to make the point that long-term urethral catheters, the main problem with them is that they can cause urethral damage, and that is for us urologists and obviously for the patients, if you have urethral damage, particularly for the ladies who are sitting on their urethral catheters, that is such a problem because that changes somebody. It affects their continence long term if you've damaged their urethra. So if somebody genuinely needs a long-term indwelling catheter, consideration should always be given to should they have a suprapubic. In general, we would recommend suprapubics over urethrals for that reason. Obviously, there are exceptions to that, and it's not right for everybody. However, if you've got hand function and you can't empty your bladder, you should be doing intermittent catheters. And that's something that I think Liam and his equivalents, are just so brilliant at making sure that patients early on get introduced to intermittent catheterization. It also gives you the option then, if you can go for a wee if you can, it's such a much better option. So I don't know if that's answered the question, but
I think that sort of addresses, I think, the questions that were raised there. Question on mirabegron. Do you find that mirabegron works best for MS patients?
I think it can. Yeah, I think it's a really good choice of drug. I like, again, like we said earlier, it's a good option to have when you've got a patient who's got maybe it has got an element of dementia, or you're worried about the cognition, particularly in MS. Yeah, I think it's a good drug. I've kind of I don't know what the general consensus. What do you think, Dallas? Is something that is being used more, do you think, overall than anticholinergic?
Oh no, absolutely. Particularly in neurodegenerative conditions, Parkinson's, even your patients with Alzheimer's who have insight, that are early stages. Clearly, yes. MS, I think more and more, because you get concomitant autonomic symptoms like constipation and dry eyes, dry mouth, and so it's a natural one. Yeah,
and then Vibegron's even better. It's supposed to be even less side effect wise as well, so that's a good choice as well, I think.
Absolutely. We have a couple of more questions here. One is on ITB for Shiva. How do you balance between the need for ITB and bladder dysfunction and retention in patients with severe spasticity?
I think it is more of a let us say a theoretical concern than a practical one, because most of the people who require intrathecal baclofen pump for management of spasticity do have severe bladder problem also. The bladder helps to the ITB. There are few case reports and case series which says that IB may reduce the bladder contraction, so it may make bladder more relaxed. So it's not usually too much of a problem. They may go in for a retention sometimes, and they maybe have to, that we need to manage with intermittent self-catheterization. Only group where I may be concerned, maybe people with HSP who may not have significant bladder problem, but we may have very severe spasticity, who may need to have baclofen pump, and then they may have to deal with the problem of retention. So probably we could, during their trial of intrathecal baclofen, before they put in the pump, that during the trial injection, this may become manifest, and they could make a learned kind of judgment as whether they want to do this to sort out their spasticity or hold on to. But that's a very small number of patients if you look at the overall thing. Otherwise, usually the spasticity and bladder problems go hand in hand.
Brilliant. And there were a couple of questions regarding your talk, Shiva. Is Fowler syndrome a differential for scan-negative CES? This individual has come across a patient with a positive urodynamic study after a negative scan for CES.
I think you will be the right person to answer it, Janesh.
Well, I suppose it would be fair to say that many of our individuals with Fowler's do have back pain, presenting tension, have bowel dysfunction. So I suppose it is a close mimic, isn't it?
Yeah, it is. Yeah, I
And
agree.
and there was a question about your case with the bladder stones that were quite large. Were they? The question is, were they insidious? Were they growing insidiously?
Yeah, I think the one of the problems is that this lady did not have much of sensations because of her MS, so she didn't recognize she did not have much bladder sensations, or she had sensory problem in the lower limb, and so she can't appreciate any pain in her bladder. So I think the stone just kept on growing. I think.
So here's a brain meets bladder question. Do you consider delirium or new confusion as a symptom of UTI, even if there's no fever or raised inflammatory markers? And
I think.
would you treat with antibiotics?
Yeah, I think the delirium, especially in elderly, frail people, may not be associated with fever. Sometimes it may be I do have one lady who has frontotemporal dementia, who has actually hypothermia and delirium due to urinary tract infection. Yes, we need to consider that as a differential and need to treat it. Yeah.
Sheila, a question on long-term prophylactic antibiotics for recurrent UTIs. Is that something you would ever recommend?
Oh, absolutely, absolutely. But that's a much bigger question. You go through the pathway, you know. So, but all of that is in the NICE guidelines, and yes, it's one of the early things we would use. Yeah, but be careful of nitrofurantoin. Um,
We have a question that hasn't been touched upon about transcranial magnetic stimulation for bladder problems. Is that something any of you have any experience with?
No.
Sorry, I haven't.
No.
I was going to pass it on to you, Jalash.
And then actually something about bowel and bladder issues, but in the context of Ehlers-Danlos hypermobility, would you recommend as often bowel issues are running alongside bladder issues in this condition? So do you find pelvic autonomic problems in patients with Ehlers-Danlos syndrome? And what would you recommend?
I think you need to treat them like any other, you know, it's a symptom-based thing. I mean, personally, I always find this like problem with Ehlers-Danlos is that people will often come into me and say they've got Ehlers-Danlos, but they have not had any formal diagnosis or often, you know, so I mean, I think you should treat the symptoms and what they are. And bladder and bowel should go hand in hand, because if you've got bad bowels, you're going to have a bad bladder.
Brilliant. Shayla, we've had a request for a clarification. Be careful of nitrofurantoin. Do you want to maybe just
This
expand
is
that?
where we need the other lecture.
We have a lot on UTIs. Is it the peripheral neuropathy that you're concerned about?
You know, long-term nitrofurantoin can cause it can cause lung scarring. It can cause significant respiratory issues. That's very rare, but it's extremely serious. It can also cause renal and liver dysfunction. So we tend to say if you're using low dose nitrofurantoin for more than 6 months, you just need to be monitored and also make an active decision to do that. Don't just, I mean, I see patients who are sometimes put them on for years and years, and I have seen patients develop respiratory fibrosis on it, and that's really serious. As I say, very rare, but any drug that you're going to use on a long-term basis, you need to know why you're using it and make an active decision whatever it is, every year, is that the right thing to do? And we've lots of options now for recurrent UTIs. So you know, it'll be unusual for somebody to have to be on that long term. Having said that, I've got some patients who find it's the right answer. You know, it is the only option. They've tried lots of other things. They've been fully investigated, and it works for them.
Liam, you're going to answer the Sheffield specific question about referral to
Yeah.
your service.
Yeah. Just going to say, if the person wants to get in touch with me directly, Liam Rice 3 at nhs.net, they'll probably find me. I'll more than happily have a chat with them about the best way to refer in. But I think generally it would be really good if you do any referrals to collect as much history as you can. It really helps us out, and then I can maybe arrange to see them in my clinic or pass them on to one of my colleagues.
Brilliant. And the last question to Sheila. We talked about estrogen creams. Now, if there's a history of breast cancer, should there be a concern about using these? Or is that something?
I was actually hoping you would ask me that question. So I have to say, first of all, I think that's a really good question, and I've struggled with this. I actually genuinely don't know if there's been any consensus on this, but when I have used it, if I've had patients with breast cancer, I have checked with their oncologist because certainly previously patients who were very estrogen positive, some of the oncologists have said no. I have a feeling there might be some more guidance on that, but that's which I don't know about, but that's what I would always do. I would be careful. I don't know if anybody else knows. Has there been anything come out recently on that? No, I don't think there is. So in which case I always check with the oncologist. So
Fantastic. Thank you very much. We were able to go through the questions, and it's been incredible. And I think it's time to bring the session to a close. As you are aware, the Neurology Academy is very much supported is part of the Neurology Academy. And I would strongly encourage you to scan the QR code to have a look at all the other activity that's going on. It's a very busy year for the Academy. In particular, I'd like to sort of just flag up that there are a couple of Parkinson's masterclasses coming on. So there's a foundation one occurring in September in Sheffield, and an advanced Parkinson's masterclass in November. There's a multiple sclerosis masterclass occurring in June, about under the aegis of the MS Academy, under the Neurology Academy. And also, I think in these times when I think as healthcare professionals we are really sort of pushed to the limits. This is a course that the Neurology Academy has developed on health and well-being, and this is a course actually for you and for you to support yourselves, and so that you can better support your patients, as a free online course about sort of wellness principles. And I'd encourage you to have a look at that as well on the website. And with that, I really would like to thank the speakers, Sheila, Shiva, Liam, for their wonderful presentations, for agreeing to stay back to answer all the lovely questions we've had. I think to thank the Neurology Academy for supporting this event and for facilitating this webinar, and the participation we've had from yourselves. We've had a lively audience. I think the number hit 220 at one point. Great. And we've got such a number even after extending into penalties. And the questions have been lovely. And thank you very much. So I'd like to draw this to an end. Thank you very much once again, and have a lovely weekend.